by two eminent sonologists. One is Dr. Manigandan, who is an UK trained and he's still in UK. He will be briefing us on the ultrasonogram, and Dr. Kanimuli, the leading radiologist from Child Trust Hospital, she will be giving us an overview of ultrasonogram of the abdomen. To moderate this session and to chair this session, we have our own executive board member, Dr. Jalil Ahmed, as a senior pediatrician from Coimbatore. So, inviting all the delegates, the senior pediatricians, Dr. Srinivasan sir, including Dr. Srinivasan sir and Dr. Nandini madam, and many senior delegates who have joined us on this platform, and happy learning on this ultrasonogram too. Welcome you all. Thank you. Over to Dr. Narbada.
Thank you, Dr. Somasundram. I think Dr. Singhanavelu sir, our President-elect IAP, CIAP has joined with us, sir. Dr. Singhanavelu sir? I cannot see him, okay. So, I think I'll hand over the platform to Dr. Manohar
Dr.
sir,
Yeah.
our academic coordinator, to take over the proceedings.
Yeah. Good evening and welcome to this black and white Wednesday series of learning. Thanks to Dr. Thangavelu sir, Dr. Rajkumar and Dr. Sri Priya. We thank you for your efforts in organizing this radiology series. Today, we are going to learn about ultrasonogram, the most versatile, highly effective, cost-effective, and painless and non-invasive tool for diagnosis. Days are not far off when most of the physicians will be having a this tool in their clinic to make decisions. We thank Dr. Manigandan, who has joined from UK, and also Dr. Kanimuri for accepting our invitation and joining us. Also, our thanks to Dr. Jalil Ahmed, who is an active learner, I can say, and also in every platform of CME learning, he'll be there giving his also his knowledge and sharing his knowledge and wisdom. Now it's over to you, Dr. Narmada.
Actually, ideally though, it is over to Dr. Nandakumar, who is the coordinator of this program, to introduce the chief guest as well as the deliberation. So now I will hand it over to both Nandakumar and Sri Priya for further proceedings. You can introduce the chief guest and start the program.
Good evening, all of you. I'm happy to introduce Dr. Jalil Ahmed, our senior colleague. He has been a past president of IAP Coimbatore during the year 2011 and 12. He was the state president of Neonatology Association of Tamil Nadu 2018-19. He was also the national EB member 2019 National Neonatal Forum. He was also the EB IAP TNSC 2020, and also he was the executive board member Central IAP 2021 and 24. Sir doesn't require many introduction. He's a senior colleague and he has been a good friend to all of us. Over to Dr. Jalil sir, who will moderate today's session and do the deliberation. Thank you, sir. Please welcome Dr. Jalil sir.
Thank you, Dr. Nandakumar. Good evening, all. The most respected President, Dr. Somasundaram, Secretary, Dr. Narmata, and the Treasurer of IAP TNSC, Rajkumar, and the Program Coordinator, Dr. Manohar, and Convener, Dr. Nandakumar and Sri Priya, and all the esteemed office bearers, especially Vice President M.S. Vishwanathan, my colleague, and most respected Professor Dr. Thangavelu, my close friend Dr. Nandini, to this wonderful, our own President's brainchild, Wow Wednesday series. I attended all the 5 series. It is really amazing. And now our President has chosen the next step, what we all wish to attend. Now, it is the most important as a clinical extension of the tool is the ultrasonogram. Here we have the 2 eminent speakers whom I know, Dr. Manigandan Chandrasekharan. During my tenure, when I was a president of NNF, he was in my office, OB team. And also Dr. Kanimali. These two eminent speakers, they are going to enlighten this important need of our program, because for practicing pediatrician, understanding the clinical implication of this imaging technology, which improves the quality of our care. So without much ado, I now take the privilege of introducing my own friend and my own colleague, who is a very humble personality, Dr. Manikandan Chandrasekharan. He is currently working as a consultant neonatologist in Liverpool Women's Hospital, NHS Trust, United Kingdom. He is a MRCPH and FRCPH and GCT in UK. His field of interest is hypoxic ischemic encephalopathy, therapeutic hypothermia, preterm brain injury, neonatal MRI brain, and EEG. Because of this special interest, he is a right person to tell about the neurosonogram, which now becomes the regular tool of a practicing neonatologist and pediatrician also. Dr. Manikandan Chandrasekharan received many awards. Doctors of Medicine in Research, University College London. He had credit to many publications, and he has written 3 chapters in pediatric books. He is a very well-known neonatologist when he was in Chennai. Now I request Dr. Manikandan Chandrasekharan for his talk on neurosonogram. Over to Dr. Manikandan.
Good evening, everybody. Hope you can see my slides.
Yes, sir.
Yeah, thank you so much. It's a great pleasure to be here on this evening, very late in Chennai. Thanks to IAP TNSC team for inviting me to give this talk. It's nice to see my teachers, presidents, my colleague members from ICH. It's a great pleasure to meet all of you. My talk today is on cranial ultrasound. As I need to disclose that I'm a neonatologist, not a radiologist, but in most neonatal units across the world, probably half of them will be all the cranial ultrasounds are done by neonatologists. So it's I hope I'm okay to talk on neonatal ultrasounds. So I would talk about initial standard views, what you would take, and then common conditions that we would do neurosonogram in a NICU, and then talk about what are the normal variations and what is that you need to look for. Luckily, in a small baby, for a neonate, we have so many windows to do ultrasound scan. There is anterior fontanelle, posterior fontanelle, temporal fontanelle, which is also called splenoid fontanelle, and then mastoid fontanelle. In the anterior fontanelle is the most thing that I will be discussing today. Temporal can be used for a midbrain and circle of Willis, and posterior can be used occasionally with for occipital views of horns and parenchyma and posterior fossa. And then mastoid fontanelle can be used to look at cerebellum and brainstem as well. When we take anterior fontanelle, we do coronal and sagittal views. In coronal, there are 5 to 6 sections, which are very important. I'll go through the standard views of them. In the coronal view, when you put the probe in the front with the marker on the right, the first one you would see is this is the frontal view. You see interhemispheric fissure. I hope you can see the markers there, and then frontal lobes, which you can see on both sides, and then the orbital ridge. If you go further down slowly, and you would continue to see the interhemispheric fissure, both frontal lobes continuing, and there's a clear double-layered corpus callosum. And then cavum septum pellucidum just below that. It is only seen in preterm babies, not in term babies. It's usually closest by then. And then you can see both sides. There's a frontal horn of lateral ventricle. And then as you go down, you can see a head of caudate nucleus and putamen and globus pallidus there. As you go behind from front to back, you continue to see the corpus callosum, and now you can see the body of the lateral ventricle on both sides, and then you can now see third ventricle, where it's connected to the lateral ventricle through interventricular foramen of Monro. And this is a very important view when you want to measure the ventricle size in PHVD, which I'll be covering later on today. Continue to see the deep gray matter. We've seen the basal ganglia early on, and now we can see the thalamus a little bit more clearer. This is also an important finding in this view, which would be really useful. And when you go further backwards, you can see the posterior horn of the lateral ventricle and with the choroid plexus, very bright, as bright as the bone. You can see the skull and the blood are generally as bright, equally bright. And then you can still see the interhemispheric pressure, parietal cortex. In the next to the posterior horn of the lateral ventricle, there's a blush formed by the normal white matter, so you shouldn't mistake that for PVL. And when you go to the posterior most of the cranial ultrasound, the coronal view, you can see this white matter forming the periventricular blush again very clearly. And then this is where you would see a lot of problems in preterm babies sometimes when you want to look at for cystic PVL or a diffuse PVL. Then we come to the sagittal views. In sagittal views, you can see the midline one, which is very important view. You can see the double-layered corpus callosum very clearly here. And then in the dark area just below that is cavum septum pellucidum. And then the guitar shape one, or a lady in the dress, as we call it here, it is the cerebellum which forms a part of the dress here. And then in front of the cerebellum, you can see the fourth ventricle, and then the whole midbrain pons medulla comes in there. This is one of the important view to see how the midline, and this also rules out any congenital anomalies at this stage. And then when you go parasagittal view, just slide across. I forgot to tell you that when you do the sagittal, the marker should be fair on the front for the sagittal ultrasound probe. On the parasagittal view, you can see the lateral ventricle in a darker circle here. And then this is an important view for a preterm babies where we identify IVH very clearly in this place. So you have a caudate nucleus there, and then thalamus here. In the caudothalamic groove where we have the germinal matrix, that's where usually the bleeding starts. So this is a very important view to see what is normal and what is abnormal. And this bright area is a choroid plexus, and rest of the parenchyma looks normal. So this is very important to note. As we go laterally in the parasagittal view, you can see again the parietal white cortex looking around here, and then Sylvian fissure here. These are the common views that we would do. These coronal and sagittal views are very important in a neonatal unit. And further studies we can do are Doppler studies. It usually helps us to assess the cerebral blood flow. And sometimes vascular abnormalities like vein of Galen can be seen in here. The importance of resistance index I'll cover in the HIE when I come to that. This is where when you put a color Doppler in the sagittal view, you can see the blood vessels clearly there. And if you want to measure the resistance index, you put the pulse wave Doppler across it, and you can see the waveform coming clearly, the systole and the diastole. And usually RA is calculated based on the beginning of the peak as well as the end of the peak, and that distance will be there. There are other fontanelles which we can do. I'm not going to cover in deep because of the time, but I'll just show you just a brief picture. In the posterior fontanelle, occipital fontanelle, you can see the occipital horn of the lateral ventricle very clearly, and then surrounding occipital cortex. In the temporal fontanelle, we usually do it for brain stem, midbrain areas, as well as the circle of Willis. If you apply a Doppler here, you can see the circle of Willis here. Sometimes in stroke newborns, it is useful to see that. In mastoid fontanelle, you can see the cerebellum and posterior fossa very clearly. You can see both the lobes of cerebellum here, and sometimes cerebellar bleeding is common in preterm infants. I would recommend not to do this routinely, these other fontanelles. It does take a lot of expertise to do, so we only do it in occasional situations. So routinely, we only use the anterior fontanelle for all the screening. So if we go through some of the cases that we do, so for example, in a term babies, this is the case scenario you probably would come across very often. Term baby, term gestation, mom had been in labor for past 4 hours, suddenly complaining of excruciating abdominal pain, became hypotensive, and fetal heart rates were not there. So she's been taken for emergency C-section. And the baby was born in an unresponsive, floppy neonate with no respiratory effort and heart rate of around 80 beats per minute, needing IPPV, positive pressure, and intubation. Initial Upgar scores were like 1, 4, and 7. And then cod pH showing gas was very severely metabolic acidosis with a pH of 6.9 and base deficit of 18 and lactate of 15. A neuro exam in the neonatal unit shows encephalopathy and also has a seizure at 4 hours. This typifies the pictures of a baby with HIE. So when we do a scan in HIE, what to look for? There are several phases in HIE which you can see in the ultrasound. In the acute phase, between 24 to 48 hours, you would only see cerebral edema, not much to document there. But in the subacute phase, like 4, 5 to kind of end of the week, the pattern can be clearly seen. There are 4 patterns described in the literature. Generally, in near total asphyxia, deep gray matter injury is the predominantly common. In partially prolonged asphyxia, watershed injury there, so the cortex and subcortical white matter will be involved. And then in partial asphyxia and sustained hypoxia, primary white matter injury will be there. And then in terms of partial and near total asphyxia, when you have an unfortunate instance like that, you will have a global injury in there. In chronic phases, like after weeks after injury, you could see the brain volume loss, ventriculomegaly, and then widening of subarachnoid spaces. If you see this in the acute phase, you would see a cerebral edema. I don't know how much you can appreciate in the screen. On the left side is a normal brain where you can clearly see the cavum septum pellucidum, corpus callosum, and the deep gray matter here in a normal definition, clearly sulci and gyri, and you can see there. But on the right side is a cerebral edema and HIE where you cannot see these clear differentiation of sulci and gyri or gray and white matter differentiation, or even for a ventricle for that matter. In the subacute phase, as I mentioned, about 5 to 7 days, you can start to see more changes in the cranial ultrasound. So early phase, you can see slowly developing. This is an abnormal echogenicity. As we go along, you can see more echogenicities here. And in the bottom row, it's all very severe HIE. You can see the deep gray matter and thalamus are much more hyperechogenic here. And then you can see in the white matter as well in the global injury, white matter.
Ani, sorry to interrupt. We can't see your mouse on the screen.
Oh.
Were you pointing to structures? Can you just
Oh, okay. I don't know how to.
minimize and no, just stop share and share again and see if it works.
Okay. Let me try that.
And you can use the pointer available in the Zoom itself. That will be more brighter.
Okay, let me share now. Can you see now with my arrow?
Just movement, you are not able to see.
You're not able to see. The annotate in the Zoom is not working. I think.
Now it is coming. The cursor is there.
Which cursor is coming?
White cursor is there. You can. Yeah.
It's coming? Okay, fine.
Yes,
I'll use
yes.
this one. Okay. So I was just saying about the subacute phase where you can see more injury here. So it starts to appear in the deep gray matter here. And as we go along, you can see further injuries in deepening. And then this is a severe form of injury in the bottom row, where you can see the more injury in the caudate nucleus, thalamus. And then we call this as a tram track, where this myelination is not there in the posterior limb of internal capsule, which is very well seen in the MRI rather than ultrasound. But still, you can see there are abnormal echogenicities here in between the unmyelinated plaque. And you can see more white matter injury as well here in the cortex and subcortical region in the global injury situation. This is seen usually 5 to 7 days after the HIE, and roughly around the same time we do the MRI as well. It's very useful in prognosticating. Why we do ultrasound in HIE is it is a strong marker and it correlates with MR brain injury as well, as I said. In HIE, we also do the resistance index. We used to do it very routinely in all HIE babies. Now that we cool, the prognostication in RA is not that great, so we don't do it routinely. So the normal RA in term infants is around just above 0.6. It's been there for decades, and they've proven in many decades ago that it is very useful to, if the RA is low, that tells you that the reperfusion injury is more, and when you do the scan between the day 1 to day 3, that gives you a good predictive value with a good sensitivity of 100% and specificity of 81%. But as I said, in therapeutic hypothermia, even though the cranial ultrasound studies show that general ultrasound is good, but it is not as good as as a prognostic indicator when you do Doppler. So we come to the preterm babies. It's probably a similar scenario that you would see in a 24-weeker. There was no steroids given in a born by normal vaginal delivery, and with a weight of 520 grams. Baby was intubated because of poor condition at birth and ventilated on oscillator. Received 2 doses of surfactant for a high FiO2. Had a chorioamnionitis around the time of delivery. Mom wasn't given antibiotics, day 1 ultrasound showed no IVH, but day 3 on oscillator, needing around 65% oxygen on full PN and trophic feeds, and also on inotropes and hypotension. Suddenly become unwell with the increase in oxygen, more hypotension, metabolic acidosis, pale and shocked with the bulging fontanelle, and this is their scan. And obviously you can see with the lot of blood. This is abnormal bright echogenicity you can see in the ultrasound, and it's filling the ventricle, and it's also extended to the parenchyma here. And this is sagittal section. On the coronal section, you can see it is extended to the parenchyma here. So this is grade 4 IVH. So the grades in IVH have been described many decades ago, like subependymal hemorrhage is grade 1, and grade 2 was IVH without any dilatation, and grade 3 is IVH with ventricular dilatation, and grade 4 is the IVH with parenchymal involvement. Currently, Volpe slightly changed the grading. Grade 1 is, instead of saying the grade 1, 2, 3, 4, we describe what we see. As we say, GMH is germinal matrix hemorrhage, or GMH with IVH, which covering less than 50% of the ventricle with the blood. And then if it is more than 50% of the ventricle is grade 3 equivalent, with or without ventricular dilatation. And then GMH with IVH with parenchymal involvement. In grade 1, you can see it's just the GMH. As I said, this is the sagittal section, this is the coronal section, and you can see the dark ventricle, and this is the caudate nucleus and thalamus. And in the caudothalamic groove, we have the germinal matrix, and this is where the brightness is. So this is grade 1 IVH. The brightness of blood is usually seen as brightness of the skull. So that's when we know there is blood in there. So similarly, you can see in the coronal section as well, there is brightness just in the caudothalamic groove. If we go to grade 2, that is slightly more bleeding in the ventricle. You can see this is the coronal and this is the sagittal. You can see there's more blood there. This is the origin of caudate and thalamic groove, and then it's mixed with the choroid plexus, so it looks like very worse, but this is the blood you can see, which is a grade 2. And then in grade 3, as I said, there's more bleeding, covering probably up to 50% of the ventricle, and then there's ventricular dilatation as well in this. And then grade 4, as we saw with the case scenario, there's a parenchymal involvement in here. In terms of when we have the grade 3 and grade 4 IVH, where there is high risk for ventricular dilatation. So we do weekly scans after that once they have a grade 3 or grade 4. So we measure the indices so that we can monitor and see whether there is any intervention that we need to do. So we measure, there are 3 indices around, but most of us measure across the world only the ventricular index. There's a VI, it's from the midline to the most dilated part of the lateral ventricle. This view should be what I shown you in the second view of coronal section, whereas the lateral ventricle meets the third ventricle with the interventricular foramen of Monroe. That section should be the constant view so that we have a same measurement every time when we do these measurements, because this needs to be monitored regularly. And then the other measurements which are really useful are anterior horn width, where the roof and the floor are measured in the anterior horn, and then the thalamo-occipital distance, where the most part of the thalamus and the most dilated part of the ventricle in the sagittal view, that can be done. So these all indicate how the ventricles are getting bigger in the horizontal way or in a vertical way. Sometimes this may need early intervention as well. This is a VI chart. We plot it and see where the markers come. So this in the x-axis we have the gestation, and in the y-axis we have the ventricular width in millimeter. So once you do the scan weekly, we plot it in the graph so that we can see how the progress is. This is the 97th of centile of the normal, and this is a +4 millimeter. When it is above 97 centile with the clinical symptoms like apnea or sunken eyes or bulging AF fontanelle, we would start the intervention. But without any clinical symptoms, if it goes above the 4 millimeter above the 97 centile, we would start interventions. So the interventions can be like we do a couple of ventricular tap or a lumbar puncture, whichever is feasible with the baby. If that doesn't improve it, then we'll send the baby for shunting. So this is our protocol for the premature babies. So for all babies born at less than 36 weeks gestation with a birth weight of less than 1.5 kilo, initial scan to be done as soon as the baby is stable. We say within the first 48 hours, there should be a scan. And the next scan would be around the end of the week, 5 to 7 days, to check for any bleed which has not happened, or if the bleed has happened early, then what is the progression of the bleed. And then next one, if both the scans are normal, then we do it for 4 to 6 weeks later to look for any cystic PVL or any problems, any new problems that we can see. And then if that is also normal, then we do at just around 36 weeks to term gestation, whenever the discharge, baby gets discharged, whichever comes early. If there is any abnormality we see with the IVH or grade 2, grade 3, then we would follow much more closely than this. We do routine probably head circumference as well weekly, and then we would do more frequently if there is any grade 3, grade 4 IVH. Why we do these scans in terms of low grade IVH, even the grade 1 and grade 2 can be very devastating to the babies. These are the studies which combine the outcome of grade 1 and grade 2 IVH, and there is increase in CP even if you have a grade 1 IVH up to 35% in some studies, and grade 2 IVH can have a CP up to 55%. So it's important to keep that in mind. Sometimes we counsel grade 1 and grade 2 doesn't matter, don't worry, but depending on what are the changes in the parenchyma or in other forms of the brain, it can cause more neuro disability or probably impairment of neural function. And in terms of severe grade IVH, which is grade 3 and grade 4, the outcome can be devastating. The CP rate in a grade 4 bilateral IVH can be 90%. So we just need to be careful when we counsel these parents as well. So it's really useful to understand and find out which grade the IVH belongs to. The other important condition that we come across in preterm babies is PVL, which is also very common when there is ischemia, inflammation around the time of delivery, or even a baby develops like NEC or sepsis. Then these immature pre-oligodendrocytes undergoes lots of changes during the development. So the outcome is devastating with the necrosis of those cells, and it results in PVL. It also has 4 grades. I'll show you the picture and explain that 4 grades. Sometimes you see a blush or a flare, as I explained in the first few slides, which is a crossing of the white matter, which is usually normal, nothing to worry, and it is usually seen in this sagittal and coronal. But if it is very bright and it is as bright as the bone, then you need to be worried, and that would be a grade 1, particularly if that persists for more than 7 days. So you'd have to repeat a week later to see if it still persists. That would be a grade 1 PVL. Slowly, this PVL can change into cystic PVL. I hope you can see this is the coronal section where you can see some cysts here. And then in the sagittal section as well, periventricular region, you can see some cysts. If in the frontal parietal region, small number of cysts, this is grade 2. If the number of cysts increases in some devastating cases with extreme preterm babies who didn't have steroids or antenatal magnesium sulfate or had a inflammation around the time of delivery, like with the chorioamnionitis or NEC or sepsis later on, or severe hypoxic injury as well. These can result in severe PVL like this. Similarly, grade 4 would be bilateral, and it's almost involving cortical, subcortical region, and periventricular region as well. So this will be grade 4. All these grades are very important so that we can counsel according to these severity of the injury. These are the common 3 things that we see in NICU. I just want to cover some normal variants, and one of them is choroid plexus cyst. You can see this is the coronal section where the posterior horn, where the choroid plexus is there, and you can see the cyst is there. Single cyst usually doesn't matter, but if you see multiple cyst and bilateral, then probably some things you have to investigate, like torch infection or karyotyping or some form of chromosomal anomalies like trisomy 13 or 18 can be seen as well. So you need to investigate further. This is subependymal pseudocyst. So similarly, this you can see soon after, even in the first scan. Sometimes antenatal germinal matrix hemorrhage can result in this, or sometimes even the torch infections can be associated with this. So you just need to see. So you can see this is a thalamus caudate in the same germinal matrix region where we see the grade 1 IVH. You can see the resolution in cyst formation, and that could be the subependymal pseudocyst, and you can see in the coronal section here as well. There's a cavum septum pellucidum. We discussed this. This is the central dark region in between the frontal horn of both the ventricles, and is usually closes at birth. A very small percentage can persist at birth, and it sometimes closes at 2 to 6 months after birth. There's another septum called cavum septum vergae, which is behind the septum pellucidum. This is between the bodies of the lateral ventricle, and this is posterior to foramen of Montrey. This usually begins to close at 6 months of gestation. And cavum villi interposti can be next one in the posterior extension of cavum septum vergae, and this can be seen only in very preterm infants. It's closer to the posterior horns of the lateral ventricle. You can see sometimes conatal cyst. This might be mistaken sometimes as a cystic PVL, but it's not. It's usually superior lateral to the frontal horns, and you can see in the coronal section next to the ventricle, well-defined cystic-like structures, and these are a normal variant seen in 0.7%. This is where I'm going to stop to say that the neurosonogram is very useful bedside investigation in NICU. It's important to know what is normal and what is a common variant and what is abnormal, and it's important to have some form of guideline so that when you need to repeat, when you want to access in there. Thank you. Any questions? I'm happy to answer.
Dr. Mani, please stop sharing your this thing. Thank you.
Sure.
Wonderful presentation, Dr. Mani. As usual, this is very important topics. Those days we used to diagnose the intraventricular hemorrhage or hypoxia on the day 3, as you have mentioned. Any preterm babies suddenly become pale and hypoxic, then it is proved, unless proved otherwise, it's an intracranial hemorrhage. So because I worked with pre-ultrasound era also with just only available radiology equipment is X-ray. So you have mentioned about the common scenario like hypoxic ischemic encephalopathy and the hemorrhage, intraventricular hemorrhage. So these can be easily picked up as a regular examination. I can say it's a clinic extension of the clinical examination. You have to go for the neurosonogram. That was a wonderful talk. We will take the question and answer at the end of the session. Is it okay?
I'm sorry, I need to go for work at the moment. I need to take the handover.
And
If it would be better if we take the questions now. Sorry to
1
force
minute.
you guys.
So far,
That's
in the chat box, there is no questions. Dr. Thangavelu sir, is there any question?
And no question chat box, sir. If any question you can ask. Otherwise, probably Mani can go because he has to hand over his duties.
Fine. Thank you very much, Dr. Mani, for
Thank
your
you so much,
excellent
everybody.
presentation.
Nice to see you as well. Thank you so much.
Yeah, thank you so much for joining us.
Thank you. Bye.
So now we move on to the next speaker, Dr. C.B. Kanimali. He is an undergraduate and postgraduate training from Madras Medical College, and is a specialist training at Great Ormond Street Hospital, UCLH, London. Currently, he is the head of the Department of Pediatric Radiology in Child Trust Hospital, Kanchi Community Child Trust Hospital, Chennai. And he was an executive committee member of Indian Society of Pediatric Radiology, editor, national newsletter of Indian Society of Pediatric Radiology. He is going to enlighten us on abdominal ultrasound. Again, the abdominal ultrasound examination is part of the extension of the clinical examination, and I request Dr. Kanimali to enlighten us. Over to Dr. Kanimali, please.
Yeah, thank you, sir, for the introduction. Let me share my slides. So can you see my slides now, sir?
Yes.
Okay. So this topic is a little bit tricky compared to all of the other radiology topics you've seen, because as pediatricians, you will not be performing ultrasound abdomen. So I thought what might be useful is to show you what ultrasound abdomen can be used for, and also to understand the reports, kind of to make sense of what the reports mean and what you need to do next when you see a particular report. So we'll start with the most common indication for ultrasound abdomen, RAF pain and lower abdominal pain. And of course, the top DD for that would be acute appendicitis. And this is what we're looking for in acute appendicitis. So we're looking for a dilated, thickened appendix, and these are the ultrasound criteria. So the appendix needs to be more than 6 millimeters in diameter. It's a non-compressible aperistaltic blind-ending structure in the RAF. Here's another example of a dilated appendix. So the appendix always sits on top of the psoas muscle. This is the psoas muscle here, and on top of that, you've got this blind-ending structure. In contrast, this is what a normal appendix will look like. But it's always not as straightforward or as easy as this to see an appendix. In a lot of cases, we're not able to see the appendix. So a lot of the residents who send the scans will always say, can you mention the size of a normal appendix? In about nearly 70% of the cases, we don't see an appendix. It's quite normal to not see the appendix. So what happens when you don't see an appendix? Is the study indeterminate or not? So what we need to look for is other signs of appendicitis. So the secondary signs. So whenever you send a patient for an ultrasound and the report comes back to you and there is no mention of what the appendix is, or there's no appendix measurement there, look at the report to see whether they've mentioned these associated findings. So have they mentioned anything about free fluid in the RAF, increased echogenicity of the fat there? Is there bowel wall thickening? Or their dilated bowel loops? All of these are secondary signs of appendicitis. Even if the appendix is not actually seen, all of these other things indicate that there is an inflammatory process going on in the RAF, and indirectly it means that there is appendicitis. So I'll show you a few examples now. So here are two patients on your screen. So one is on the left side, you've got a 14-year-old boy who has right-sided abdominal pain for 4 days. So this is a zoomed up view of the RAF, and this black region that you see is free fluid in the RAF, and anterior to that, this echogenic structure is thickened omentum. And similarly, in this 11-year-old girl who has right-sided abdominal pain, again, you can see that there is echogenic free fluid. On top of that, there is thickened omentum. So all of this shows that there is inflammatory change. In both these children, the appendix was not seen separately, and at surgery, both had perforated appendicitis. Here's another example. This is a 10-year-old girl who had lower abdominal pain for 4 days. And this is an image of the RAF. And within that, you have this collection. So all these bright specks that you see within it is gas. So there's a collection which has gas within it. And then this is the bladder, and you can see that this collection is compressing the bladder. Again, here the appendix was not seen. This was a perforated appendicitis with collection. So the presentation in this child, who's a 7-year-old, was vomiting and abdominal pain. And clinically, there was suspicion of small bowel obstruction and was sent for an ultrasound. So these are all dilated small bowel loops. Within these, can you see all these white lines? These are the valvular conjunctives, and that tells you that this is small bowel. So there's dilated small bowel, and so you got to think of small bowel obstruction. So now we need to find out the cause for the small bowel obstruction. So here's an image of the RAF, and in that you can see there is free fluid, there's bowel wall thickening, and further down in the pelvis, there's the bladder. Again, there's a big collection there in the pelvis. Once again, this was a perforated appendicitis with collection causing small bowel obstruction. So these images are just to show you that in cases of appendicitis, you need not always see an appendix. Sometimes you might see that dilated blind ending tubular structure, but in a lot of cases, we don't end up seeing the actual appendix either because it's perforated or it's buried within all of this inflammatory change. So what we look for essentially is changes of inflammation in the RAF. Are there any collections? Is there bowel wall thickening? Is there mesenteric thickening? So if there is a mention of any of these in your report, that should raise a suspicion of appendicitis or perforated appendicitis, and it would be wise to get a surgical opinion in such cases. And also they can have atypical presentations. So this was an 11-year-old boy who had increased frequency of micturition, and he was referred for a scan with query UTI because of the increased frequency of micturition. So this is an image of the pelvis. So this is the bladder. And next to this bladder, you can see there is this dilated blind ending structure. So this was a pelvic appendix which was inflamed. And because that appendix was irritating the bladder, this boy had increased frequency of micturition. So beware of atypical presentations also. This was a 1.5-year-old girl who had a history of limp for 4 days, was seen by a general practitioner outside, and because of the limping was referred to the orthopedician at our hospital. So the orthopod sent it for a scan to me with information as query transient synovitis. And this is the image of the hip. So this is the neck of the femur. This is the metaphysis. And because this is a 1.5-year-old child, you can see the physial plate, and that is your femoral head. So this is where we look for a effusion in the hip joint. This is a normal hip joint. There was no effusion in this. Now, in all cases of hip ultrasound, we always look at the psoas because any abnormalities in the psoas can also give rise to the hip problems. So when I moved up to the abdomen to look at the psoas, what I found was anterior to the psoas, there is this large collection. Again, there's this thickened fluid, and all this bright stuff that you see here is thickened mesentery, and there are bowel loops which are also involved in this collection. So this was in fact a perforated retrosacral appendicitis, and that because of that pain, the child was not moving that side of the body, and that leg was not being used. So it was mistakenly thought as a hip pathology, but was actually a perforated appendicitis. So we look at some of the causes of acute RAF pain. Here's an 11-year-old girl who had right lower quadrant pain for 2 days. Image of the pelvis. This is the bladder. And behind that, this is the right ovary. So now I'll bring up the left ovary for comparison. So if you look at the two, you can clearly see that the right ovary looks much larger and the definition is not there. So if you look at the left ovary, all these little black holes that you see within it are the normal follicles. So in any normal ovary, you should be able to make out the definition of those follicles. Whereas in this right ovary, you can see it looks much enlarged, more globular, and that definition is lost. So whenever you have an enlarged ovary, the first thing that we need to think of is ovarian torsion. So the key to diagnosing ovarian torsion is your ovarian volume. So if you look at the volume of the ovary, so this left ovary is around 5 ml, whereas the right one you can see is around 19 ml. So this is ovarian torsion. When there is a difference of around 3 to 4 times a difference in the volume between the ovaries, that is an indication of ovarian torsion. So a lot of the time the residents come up and ask, what about the flow within the ovary? Were you able to see any flow? In ovarian torsion, blood flow is not a reliable indicator of torsion. This is in direct contrast to testicular torsion. So whenever there is testicular torsion, the first thing we look for is the flow within the testis. If there is no flow within it, we say it is tossed testis. But that's not the case for ovarian torsion. Even a tossed ovary will have some flow within it. So where the presence or absence of flow in an ovary is not a good indicator of torsion. What we rely on is the ovarian volume. So look at the size of the ovary and the ovarian volumes in your report. Okay, this was a 3-year-old girl who had right-sided pain. This is an image of the kidney. You can see there is dilated collecting system. This is the ureter, and within this ureter, there is a large calculus, a nice aftershadow from that calculus. This was a ureteric calculus. Here's an image from a 9-year-old boy who had pain for 2 days. This is the kidney, and there is a lower pole renal calculus. Here's a 3-year-old who had fever for 4 days and severe right-sided pain. So these are images of the kidneys, cross-sectional image and then a longitudinal image. And within the upper pole, you can see there is a well-defined hypoechoic lesion, and this was a renal abscess. A 6-year-old boy who had fever. So this is a longitudinal image of the RAF. This is the psoas muscle. And as you go up, you can see that the psoas muscle is bulging. On top of the psoas, you can see part of the kidney. So this muscle, psoas muscle is widened, it's bulging, and within it, you can see fluid. This was a psoas abscess. And when this was aspirated and it grew staph. Okay, this is an 11-year-old girl who had abdominal pain for 3 days. These are images of the upper abdomen. So this is the vertebral body, this is the midline, and this is the pancreas. So you can see the pancreas is very much edematous and enlarged, and anterior to the tail, there's a large collection. So this is acute pancreatitis. Now, I want to stress that ultrasound is not your modality of choice to diagnose acute pancreatitis. It's a clinical diagnosis. It should be based on your amylase lipase levels. So there is no need to get an ultrasound to diagnose acute pancreatitis. The main use of imaging, ultrasound or CT will be later on in appendicitis, around the 2nd week or after 10 days. And the use is to diagnose complications arising from the appendicitis. So you want to look for pseudocysts. Is there necrosis of the pancreas? So those are the things that imaging is useful for. At diagnosis, your amylase lipase levels will tell you whether there is an acute inflammation or not. So this was a child who was diagnosed with acute pancreatitis. This is the 2nd week, and a scan was done. So this is the vertebral body, the aorta. And here is where you would see normal pancreatic tissue. So here, you're not able to see much of pancreatic tissue because most of it has been necrosed. And anterior to the pancreas is this large complex pseudocyst. Okay, so we'll move on to the next set of cases. Now, abdominal pain, query mesenteric adenitis is a common request for an ultrasound. And this is a report that you may get when you send these patients for scans. So a 7-year-old boy who had recurrent abdominal pain, and then query mesenteric adenitis, and the scan comes back to you saying multiple enlarged nodes measuring 5 mm, and features suggest mesenteric adenitis. So here's an image from a representative child. This is a RAF, and these are all the nodes that are in the RAF. Now, these are all normal nodes. In over 95% of the children I scan, they all have nodes in the RAF. This is part of the normal spectrum. This is not mesenteric adenitis. So mesenteric nodes are often seen in normal children, and this is a good paper that talks about the occurrence of mesenteric lymphadenopathy in children with recurrent abdominal pain. So in a nutshell, what it says is that mesenteric nodes are a non-specific finding, and it's clinically irrelevant as a cause of abdominal pain in school-age children. And they suggest using a cutoff of around 8 to 10 millimeters as a node size to diagnose primary mesenteric adenitis. So primary mesenteric adenitis is a self-limiting inflammatory condition, and the presentation be pain, fever, and vomiting. In contrast, secondary mesenteric adenitis will be because of an underlying cause, some other underlying inflammation. So here's an example. This was a child with enteric fever, and you can see that there are enlarged nodes. So if I bring up the previous image, you can see the difference between the two. Normal nodes have this sort of oval configuration, whereas an enlarged abdominal node will become much darker. So it'll look much more hypoechoic, and it'll look much more rounded. Here's an example of a TB node in the RAF. Again, you can see that this node, instead of being oval, is very rounded and very hypoechoic. Okay, another common indication for ultrasound would be bleeding PR. So we'll look at some examples of that. This was a 4-year-old who had 3 episodes of blood in stools and was sent for an ultrasound. This is an image of the right lower quadrant. And here you can see there is a cyst. Both of these images show that. And on this image, this white shadow with this artifact behind it, you can see, is because of air within this cyst. And if you look at the cyst wall, I hope you're able to make out this sort of double-layered appearance. So there's one bright line and then a much darker hypoechoic line. So this is known as your typical gut signature. This sort of double-layered appearance tells you the origin of the cyst is from the gut. And then we're seeing air inside the cyst as well. So that shows you that it is in communication with the gut. That's how the air has got into it. So you correlate it with the history. So there's a history of blood in stools, and we're seeing a cystic structure with a gut signature in the right lower quadrant. So your first diagnosis here would be a Meckel's diverticulum. And this child was sent for a Meckel's scan. So this is the Meckel's scan. Each of these frames is like a 1-minute sequential image. So what they do is they give the technetium dye and sequentially image it. What you're looking for is the uptake in the stomach. So in the left upper quadrant, this dark area is the gastric mucosa that normally takes up the dye they give. And if there is any ectopic gastric mucosa elsewhere, at the same time that the stomach takes up this dye, you'll see an ectopic spot elsewhere in the abdomen. So if you look at this scan, you can see the stomach has taken up the dye, and in the right lower quadrant, you're getting another blob that has taken up this dye. So that means that there is ectopic gastric mucosa in this region. So this is what a positive Meckel's study will look like. So dye within the uptake in the right lower quadrant of the abdomen, which is equal to the dye intensity in the stomach and occurs at the same time and with the same intensity as what is taken up by the stomach. And this was the intra-op picture for that child. So you can see the classical Meckel's in the anti-mesenteric border. This is the ileum. This is the mesentery. So from the anti-mesenteric border, you've got this Meckel's diverticulum coming off. Here's the next case. This is a 3-year-old with abdominal pain for 1 day. So I'm sure all of you would have seen these pictures. So this is your typical donut appearance. And then on a longitudinal image, this is your pseudo-kidney appearance. This is classical ileocolic intussusception. So what about small bowel intussusception? You might have seen reports which say there's bowel within bowel appearance, left side of the abdomen suggestive of small bowel intussusception. So this was the report from a scan that was done at an outside hospital and was sent to us for a second opinion. This is the image from that child. So you can see this is the left upper quadrant. And this is a small bowel intussusception. Now, small bowel intussusception is seen very commonly in children. It is a transient finding. So what is usually done to differentiate this from pathological small bowel intussusception is you just rescan these children. So this was what was seen on the initial scan. 20 minutes later, repeat scan was done in the same region. You can see that there is no intussusception there any longer. So a lot of these intussusceptions are transient. It is a normal finding, and it is not a cause for alarm, and it is not the cause for the child's abdominal pain either. But can you dismiss all small bowel intussusceptions as normal? No, you can't. So these are the red flags for small bowel intussusception. The key thing here is persistent. If the intussusception is persistent, that means it's abnormal. And then we look at the length of the intussusception. If it's a long segment that has intussuscept, again, that is abnormal. And if the scan report tells you that there are other abnormal findings, so there are dilated bowel loops signifying that there is small bowel obstruction, or there is some lead point, like they're seeing a mass inside that intussusception, that is again abnormal. Amongst all of these, the most important thing is that it is persistent. So if you find a report that tells you transient small bowel intussusception was seen in the left quadrant or right lower quadrant, I would dismiss that because it has that word transient. So transient small bowel intussusception is a normal finding and is not a cause for alarm. Whereas if it's persistent and remains the same on the follow-up scans, then it is abnormal. So I'll show you an example. This was a 9-year-old who had acute abdominal pain for 1 day, and this was the left upper quadrant. So we saw an intussusception there. We rescanned this patient after half an hour to 40 minutes, and the intussusception was persistent. This is a longitudinal image of the intussusception, and the length is measured. You can see it's around 4.5 centimeters, which is abnormal. So a normal short segment transient intussusception will never have such a long segment. So this was abnormal, was reported as jejunal intussusception, and the child went to theater, and this was what was found. This is the introp specimen. Inside that intussuscept segment, there was a polyp, and this was the HPE. So there was a gastric heterotropia inside that polyp, and that was a cause for the intussusception. Here's another example. This was a 4-year-old who came with vomiting and bleeding. And this is from the right lower abdomen. Again, you can see there is a small bowel intussusception. Again, this was persistent on repeated scans. So the child was scanned at 20-minute and 40-minute intervals, and it remained persistent and in the same spot. Again, a longitudinal image showing that it is a long intussusception. It's around 5.5 centimeters in length. This was reported as ileoileal intussusception. Child was taken to surgery, and the lead point here was a Meckel's diverticulum that was causing this intussusception. So that was the general abdomen bit. So now we'll move on to renal ultrasound. Just very quickly a look at that, because this is a source of a lot of errors and confusion. Here's a first case. So this was a 10-month-old boy who had febrile UTI and high-grade fever, and he was referred to a hospital with this scan report already done outside. He continued to have persistent fever, so he was referred to us. So the report done outside said that the right kidney measured 7.4 and the left measured 5.8. Cortical echoes are normal. There is no hydronephrosis, and it was reported as normal. So let me draw your attention to the size of the kidney. So the left kidney is measured at 5.8 and the right as 7.5. So if you look at the renal size, you can see there's a difference of around 1.5 centimeters between the two kidneys. Now, in an adult patient, that sort of difference is normal. So this is where the difficulty comes in. If it is a person who does routine adult ultrasound and is more proficient at doing, or a vast majority of the practice is only scanning adult patients, this will not seem abnormal to them, because in an adult, the left kidney is always bigger than the right, or sometimes even the right, but a difference of around 1 and 1.5 centimeters between the kidneys in an adult patient is normal. But in a child, it is not. In a child, the kidney should more or less be equal in size. You can get a difference of a couple of millimeters, like 2 or 3 millimeters max, not more than that. Any difference that is more than 2 to 3 millimeters between the two kidneys is abnormal, and there is a pathology within the kidneys. So coming back to this child is 10-month-old. So for a 10-month-old, a kidney size of 5.8 is normal. So this right kidney is enlarged. So an enlarged kidney with a history of UTI and the child has fever, you're going to diagnose this as right pyelonephritis. So the renal size measurement is a very important concept. I think as pediatricians, you should also have a rough idea of what the renal size is at each age. So when the report comes to you, kind of have a ballpark figure in your head to know whether does this make sense or not? Are these renal sizes normal or not? So just roughly to know, at birth for a term baby, it will be around 4 centimeters. When they come to around 1 year of age, it's 6 centimeters. So you can see in the first year of life, there is a huge velocity of growth. From 4 centimeters, it becomes 6. So that's 2 centimeter growth over the first year of life. After that, the growth velocity slows down markedly. So at 1 year, it's around 6 centimeters. At 3 years of age, the average is around 7.5 centimeters. So you can see that over the next 5 years, the kidney velocity of growth slows down markedly. It grows only around 1.5 centimeters. So that is something you need to bear in mind when you look at the renal sizes to make sense of whether does this report seem sensible or not. Here's another example to demonstrate that. This is a 9-year-old who's had 2 episodes of UTI. So you've got measurements of the right and the left kidney. So once again, you can see that the right is being measured at 8.6 and the left is 7.1. So that's a difference of more than 1.5 centimeters between the 2 kidneys. For a 9-year-old, kidney size of 8.6 is normal. So this left kidney is small for this child. So with the history of UTIs, you would consider left reflux nephropathy and you would assess further. So the reasonable steps to do next would be a DMSA and an MCU. So this is the MCU from that child. You can see that there is a left-sided reflux. Here are a couple of more cases of UTI. This was a 3-month-old who had antenatal hydronephrosis and an episode of UTI 1 month prior to this. So this is an image of the bladder. Behind the bladder, we can see there's a dilated ureter. And within the bladder, there is this sort of cystic projection. This is typical for a uretrocele. So whenever we see a uretrocele within the bladder, we need to rule out a duplex kidney because yes, uretrocele you can get in a single system, but it's more common in a duplex and we've got to rule that out. So here's an image of the kidney. You can see that it's a duplex. This is the upper moiety, which is dilated. There's no dilatation in the lower moiety. So the upper moiety is what is usually associated with a uretrocele. So this is a left duplex with an upper moiety uretrocele. Here's another case. This is a 3.5-year-old girl who had recurrent UTI. This is the bladder. And behind the bladder, you can see that there is a dilated ureter. So immediately you're looking for abnormalities in the left kidney because this ureter is dilated. So here's the image of the left kidney. Again, you can see it's a duplex system. Now we know that it's a duplex because if you look at the collecting system, can you see that it's 2 separate? Instead of being joined together, there is this gap between the 2. So this is the upper moiety and this is the lower moiety. So whenever you see this sort of dilatation in both the moieties, we should always look for a ureter that joins up. So here is the longitudinal image of the lower abdomen. Here are the 2 ureters, upper moiety ureter and the lower moiety ureter. And you can see that they join up in a Y junction and they travel further down with a single opening into the bladder. So this is a duplex with Y junction of the ureters, and that is why there is dilatation in both. So these will be refluxing systems. And when it refluxes, because both the ureters are joining up, the reflux is going to go into both the upper and the lower moieties, and they end up with dilatation in both the moieties. Okay, this is a 20-day-old term baby who had antenatal left hydronephrosis and was sent for a scan. So the right kidney looks normal. It was 4.8 centimeters, which is normal for a term baby who's 20 days old. And you can see that the left kidney is very much enlarged. There's marked hydronephrosis. And here's another image. You can see that the renal pelvis is bulging out. There is no dilatation of the ureter. So an enlarged kidney with marked hydronephrosis, there is no ureteric dilatation. The diagnosis here will be right PUJ obstruction. Just a quick word on DMSA versus DTPA, because a lot of the residents have a confusion over what to order when and what each test does. So DMSA stands for dimercaptosuccinic acid. So this is a static study. What it is used for is to evaluate the renal structure and the morphology. And we would use a DMSA scan in cases of pyelonephritis. Following an episode of pyelonephritis, if you want to look at scars of the kidney, and also if you want to look at structural abnormalities of the kidney. So things like ectopic kidneys or absent kidney, and you're seeing only one kidney on a scan, and then you want to confirm whether this is ectopic or somewhere else. And then you would do a DMSA. So here's an example of a DMSA study. So in this, you can see the 2 kidneys. The lower pole of both the kidneys are oriented closer to each other to the midline, and they join up. This is a typical example of a horseshoe kidney. Now, whereas a DTPA scan is a dynamic study, it tells you the renal excretion and the drainage of the kidney. So you would do a DTPA scan when the ultrasound report says that there is obstruction. So when the ultrasound report says there is a PUJ obstruction or a vesico-ureteric junction obstruction or a ureteric stenosis. So in all cases where there is some element of obstruction is the cases where you would order a DTPA scan, because you want to look at the drainage of the kidney. You want to see the hold up at that level of obstruction. Is it a complete obstruction? How long is it taking to drain and get past that area of obstruction? So it's very important to understand the difference between DMSA and DTPA and where you would use both. So this is an example of a DTPA scan. So in all of the DTPA scans, you'll get these curves. And then there's a picture with a color on it to tell you which curve belongs to which kidney. So in this one, the pink one is the right kidney and the bluish one is the left. So a normal curve with time, it will go up as the kidney takes up the contrast, and then it should slowly drain. So the curve will go down. Whereas on the left, if you can see that the curve keeps going up, that means there is no drainage from the kidney. And if you look at the pictures, you can see there is stasis of the dye within the kidney and it's not draining well. And you're not seeing the ureter here. All of the dye is staying within the collecting system. So that means the level of obstruction is at the PUJ. So this is a PUJ obstruction. Okay, so finally a word on antenatal hydronephrosis and what you can expect on the follow-up studies. So whenever there is an ultrasound report which says hydronephrosis on the fetal scans, so the child is routinely sent for an ultrasound. Now, the timing of the ultrasound, you need to wait for at least 10 days after the baby is born to do the ultrasound. Now, the reason for this is the baby needs to establish proper hydration, the renal filtration and excretion, the cycling of that has to develop. If you get a scan within the first 2 to 3 days, the neonate will be in a state of physiological dehydration and the scan report will not be accurate. The correct degree of dilatation is not going to show up. So unless you're suspecting PUV, don't get a scan on day 1 the baby is born or even within the first week. So wait at least a week after the baby is born to establish proper hydration and feeding, and then get a scan. Only that will tell you the correct degree of dilatation. And a lot of these scans, you will find reports of extrarenal pelvis. Now, extrarenal pelvis is a normal variant. What does it mean? So these are cross-sectional images of the kidney, and that is a renal border. So if you look at this renal pelvis, you can see it's projecting outside of the renal border. So that's what that means, extrarenal. It's outside the kidney, extrarenal pelvis. And because this pelvis is not surrounded by the fat and the sinus, it can dilate and balloon up quite easily, and it can dilate. So why? So I've said it's a normal variant. So why are we getting worried about a normal variant? The reason is that in infants and in young babies, this sort of extrarenal pelvis can be an early marker of VUR or a PUJ obstruction, and hence we need to get follow-up scans. Now, there is no reason to do an MCU or a DTPA scan in these babies if the baby is otherwise well, and if there are no recurrent episodes of UTI. There is no need to get all of these other imaging studies. All these babies need are regular follow-up scans to assess the size of the kidneys, to see if the kidneys are growing well, and to assess the degree of dilatation, whether the dilatation is remaining the same or whether it's increasing or decreasing. So this is a good paper that talks about the management of these children. In literature, the recommendation, some papers recommend following up these children up to 1 year of age, and some say follow them up to 2 years of age with regular ultrasound scans to monitor the dilatation. If there is a sudden jump in the dilatation, and then you would decide to do further studies, but otherwise you would just get routine ultrasounds to monitor the dilatation. Yeah, thank you.
Thank you, madam. That was a wonderful flow of teaching slides for the practicing pediatrician. And you have mentioned right from the beginning the atypical presentation of acute appendicitis, and the mention about the mesenteric adenitis we commonly encounter, that is primary and the secondary mesenteric adenitis. many reports, the radiologists, they don't mention about the primary and secondary. They just mention about the size, both axis size. If we come across the same size in the primary mesenteric adenitis, will you decide? You said it's a normal appearance. Just comment on that. And one more thing is regarding the flow of testicles and the ovarian. That is a wonderful message, because the testicular torsion, the flow matters, whereas in the ovarian torsion, it is not mentioned. Because I just wanted to know how the ovarian volume determine what is the cause of increased ovarian volume in case of testicular torsion, I mean the ovarian torsion. The third one, you clearly mentioned the clinical diagnosis of acute pancreatitis. We all endorse. Only the CT is the best modality to diagnose the complication of acute pancreatitis. Of course, the renal scan, we know pediatricians should miss the acute pyelonephritis or the scar. So that all these messages are very important for all of us. And thank you. And any questions in the chat box, we can read to answer.
Yes, sir. Just to answer your questions, one,
Yes.
the ovarian torsion, you asked for the increase in volume. So the increase in volume is because when the ovary gets tossed, there'll be edema and hemorrhage within the stroma of the ovary. So that gives rise to the increased ovarian volume, which is what we're looking for on the scan. And the difference in appearance where you lose the definition of the follicles and it becomes increased echogenicity, that is also because of the hemorrhage and the edema that happens within the ovary. And then I think the other question was the mesenteric nodes, right, sir? I'm a little biased. I don't report mesenteric adenitis. I don't believe in that diagnosis because nearly 99% of the children that I see on a daily basis, all of them have nodes. It's a normal finding. So I don't report these nodes. In my report, I don't give a diagnosis of mesenteric adenitis at all because I see the nodes in all children. And I don't feel it's related to their abdominal pain. Secondary mesenteric adenitis, yes, when there is some other infection, like you showed, when there is enteric fever or some other enteritis, they will have nodes. So I will report those nodes as part of that finding. These nodes are related to the bowel wall thickening and, you go to investigate further. But otherwise, I feel that, the mesenteric nodes is part of the normal spectrum. Nearly all children that I scan every day have the nodes. So I don't give that diagnosis. But looking at the literature, the things that we have to look for are not just the nodes. So like I showed, the shape of the nodes will change. And also you'll see inflammation around the nodes when there is a mesenteric adenitis. Till now, I haven't seen anything that justifies that diagnosis. So I haven't given that report.
It's a very
Thank you, Dr.
fascinating.
Kanimuri. Jalil sir, I have one question to Dr. Kanimuri.
Yes, sir.
See, I also usually generally they report as mesenteric nodes. I consider them like any cervical adenitis.
Correct,
If they
sir.
have anything like tuberculosis or malignancy, anything to suggest only, I also take this as a positive one and evaluate. Otherwise, generally reassure. Whether my approach is correct or not. What do you think?
Absolutely, sir. I agree with you. Just like you said, cervical nodes, they have any cough, cold, some sore throat, you end up getting a few nodes. Those are reactive. It's part of the normal body. That's how it fights infection. It's the same thing for the mesenteric nodes. Some little gut infection, some minor subclinical inflammation, they have those nodes flare up. And, you see those nodes. I think it's just part of the normal body trying to fight whatever disease process going on, and the nodes show up. The analogy that you said is absolutely right. Just like cervical reactive nodes, you see those reactive nodes there. I don't think they're pathological. Like you said, pathological nodes will have other things associated with them.
Findings will be there. Thank you, Dr. Kanimuri. Thanks. Both of you explained in a very, very nice manner. Totally a new subject for all the pediatricians, but the way both of you presented is quite interesting. Thanks a lot. Over to Dr. Jalil.
Madam Kanimuri, madam, it is better to have, nowadays we all have point of care ultrasound in the ER room. Any big hospital, they should. The role of ultrasound, especially you have not mentioned in the blunt injury abdomen. What is the red flag in the blunt injury abdomen? Many times we come across this order for this, madam.
So blunt injury abdomen, you're essentially looking for free fluid in the abdomen. Beyond that, I think as a pediatrician to diagnose in the ER will be difficult to actually pick up the injury. So if you see free fluid, that means there is an injury and you need to get a CT. So whatever injury there is, there will always, the reaction within the abdomen will be to produce free fluid. Whether it's liver injury or spleen, pancreas, anything, there will be free fluid. So if you see free fluid in the pelvis or around the organs, perisplenic free fluid, perihepatic free fluid, anywhere you see free fluid in a trauma child, get a CT abdomen. And in the setting of trauma, a triple phase CT needs to be done. That is, in fact, the only setting where I would recommend doing a triple phase CT. In all of the other cases, a single phase CT would be enough when we do it in most other cases. So free fluid on bedside ultrasound is what you're looking for in trauma.
Again, I am happy that you have mentioned all the pediatricians should know the regular size of the kidney. Because this is very important, because many times you mentioned, the radiologists mention about the size, many times we don't concentrate. Very important in case of a shrunken kidney or a kidney with the pyelonephritis. That is a very wonderful, important point you have mentioned, madam.
Thank you, sir.
Any other questions in the chat box?
If I'm permitted,
Nandini,
if I'm permitted, madam, can Dr. Kanimuli,
Yes,
this is
ma'am.
Dr. Nandini
Please.
Kumaran from Coimbatore. I
Hello,
just
ma'am.
wanted to know, I was just thinking once you said that the ovary which undergoes torsion is about 2 or 3 times the size of the other ovary which is supposed to be normal. One
Yes.
is, can a normal ovary undergoes torsion? I was thinking usually a predisposition for a torsion of an ovary is a pathology, be it a large cyst or a tumor, be it benign like a teratoma, whatever is it. Can a normal ovary undergo torsion, or this big size is just not only due to hemorrhage edema? Could it be due to the pathology that predisposed to torsion?
Yes, ma'am, both are right. So even a normal ovary can undergo torsion. It need not necessarily have an underlying cyst or a mass in it. So
Okay.
if there is an underlying cyst or a mass, obviously that will contribute to the enlarged size. But even without any mass, a normal ovary can undergo torsion.
Thank you, madam. Thank you.
If anything else, sir?
No, sir. No other questions here, sir.
Okay. So thank you both speakers, Dr. Mani and Dr. Kanimali, for your excellent presentation.
Yeah,
and
very excellent.
messages. We learned because this is one of the important tool examination. Supporting the clinical examination. Thank you on behalf
And
of
actually,
IAP
one other point I wanted to add with permission.
Yeah, madam, please.
I just wanted to say, because the one important thing is when people have this antenatal hydronephrosis, soon after delivery, people tend to try to do another ultrasound before sending them home. Very important point was stressed by Dr. Kanimuli, that you must allow the child, because the first few days there can be a mild dehydration, poor feeding, etc. So things may look normal, and that normal thing reassures, and then they may not follow it up. So it's very, very important that we give that 7 or 10 days gap and plan the ultrasound in the second week. Unless and otherwise there is some ensuing thing like a palpable bladder or a poor stream where we are suspecting a PUB or something like that. Otherwise, I think an antenatal hydronephrosis, we should give time. That's a very, very good point stressed by Dr. Kanimuli.
Thank you, Dr. Nandini.
Tangavel sir, can we? Dr. Shreepriya wanted to add.
Thank you.
Narmada, I'll summarize it in the group. There's a lot
Yeah,
of
sure.
chat. I'll summarize it in the group.
Okay. Yeah. Thank you so much, everybody, for joining on this such a wonderful and very interesting session. And Dr. Kanimuri, thanks to you for such a clear and eloquent presentation of the facts. Your images were so very clear that we ourselves could interpret it. Hope we all get certain radiologists to give us such clear images for us to explain to the parents. Okay.
Thank you, ma'am, for having me on. Thank you, Tangavelu sir, for inviting me.
Narmada, it is a family presentation. You know that, no?
I didn't know that, sir.
Neurosonogram, ultrasound, no? Similarly,
Even
they
I
have
didn't know
family
that.
presentation from Kanimuli and Manikandan.
Oh, okay. That's really nice.
Very important.
Congratulations.
You all of us
அது
know
எனக்கு
the
தெரியல சார்.
So, but from your previous conversations, I guessed it, sir, because you asked Dr. Kanimuri to remind Dr. Manigandan. From that, I guessed okay.
see.
But
I
Dr.
was talking
Manigandan
to
is in
Manigandan.
UK, na? You are in Child Trust
She
Hospital.
was in UK and she came down.
Yeah, he travels back and forth.
Now
Oh,
also you know the reason why Manigandan lost weight.
okay.
Both
I
are-
think mostly Senthil is also doing the same thing, and you're also doing the same thing. Yeah.
both are GCT consultant. That is an unique. That's
Yeah.
why I had a doubt in my mind. I'm about to ask it also. Anyway, thank you very much for the couple.
Thanks so much. Very, very nice presentation. Thanks.
Thank
Sir,
you.
Tangvel sir, can I close the meeting? Yeah. Yeah. Okay. Good night, all.
No,
Good night.
Sripriya has to do something, or we'll summarize.
No. She'll post it in the group.